Lipoprotein little, commonly abbreviated as LPA, has evolved from being viewed as a mere marker of residual cardiovascular risk to a recognized independent and causal driver of coronary artery disease and calcific aortic valve stenosis. Unlike traditional cholesterol metrics, LPA levels are predominantly dictated by genetics rather than lifestyle or diet. To understand how LPA contributes to the genesis of CAD, it is essential to look at its unique molecular structure. LPA is essentially a modified, highly atherogenic variant of a low-density lipoprotein particle. It consists of a cholesterol-rich LDL-like core containing one molecule of apolipoprotein B100 ApoB and apolipoprotein A ApoA, a unique, highly polymorphic glycoprotein that is covalently bound to the ApoB molecule via a single disulfide bond. The ApoA protein is the defining feature of LPA. It contains multiple repeating loop-like structures known as crinkles. Crucially, the structure of sequence of ApoA shares 75 to 85% of its amino acids with plasminogen, a key enzyme in the body's natural fibrinolytic, that is clot dissolving system. However, despite this structural mimicry, ApoA lacks the active protease domain that gives plasminogen its clot busting ability. The genesis of coronary artery disease driven by LPA operates through a triad of overlapping mechanisms. It is simultaneously pro-atherosclerotic, pro-inflammatory, and pro-thrombotic. Because LPA contains an LDL-like core, it shares LDL's ability to cross damaged or dysfunctional endothelial linings in coronary arteries. Once it accumulates in the subendothelial space, LPA is highly prone to oxidation. It is then eagerly engulfed by surrounding macrophages, leading to the formation of cholesterol-engorged foam cells. The accumulation of these foam cells creates the fatty streaks that serve as the foundational architecture of atherosclerotic plaques. LPA serves as the primary carrier of oxidized phospholipids in the human bloodstream. When LPA deposits these oxidized lipids into the arterial wall, it triggers a robust, localized inflammatory cascade. This upregulates cellular adhesion molecules such as VCAM1 and E-selectin on the surface of endothelial cells, accelerating the recruitment of circulating monocytes into the plaque environment. This continuous smoldering inflammation accelerates the growth, vulnerability, and instability of the atherosclerotic lesions. The structural homology between ApoA and plasminogen creates a dangerous competitive environment. Because ApoA looks like plasminogen, it actively competes for the same binding sites on fibrin clots and endothelial surfaces. By displacing functional plasminogen with the inactive ApoA, LPA effectively blocks the conversion of plasminogen into active plasmin. This inhibits fibrinolysis, the natural breakdown of blood clots. Consequently, when a microscopic rupture occurs in a vulnerable coronary plaque, the resulting thrombus is far more stable, degrades much slower, and is significantly more likely to precipitate a complete arterial occlusion and a myocardial infarction. Approximately 20 to 25% of the global population has elevated LPA levels, generally defined as more than 50 mg per deciliter or more than 125 nanomoles per liter, placing them at a substantially higher trajectory for premature coronary artery disease. Major cardiology and lipidology societies, including the American Heart Association and the European Society of Cardiology, now recommend that every adult have their LPA measured at least once in their lifetime to accurately stratify primary prevention risk. Standard lipid-lowering therapies such as statins are generally ineffective at lowering LPA mass and can occasionally slightly increase it. Traditional lifestyle modifications such as diet and exercise also do not meaningfully alter LPA concentrations since levels are fixed by the LPA gene in early childhood. Currently, the primary strategy for patients with high LPA is the aggressive suppression of all other modifiable risk factors. Example, driving LDL cholesterol as low as possible with PCSK9 inhibitors or statins. However, highly targeted RNA-based therapies such as antisense oligonucleotides like pelacarsen are currently in phase 3 cardiovascular outcome trials. These agents work in the liver to block the mRNA translation of the LPA gene, demonstrating the ability to drastically reduce the synthesis of the ApoA protein by about 80%. The treatment landscape for elevated lipoprotein A is currently undergoing a rapid transformation. Because traditional lipid-lowering therapies like statins or ezetimibe do not meaningfully lower LPA, researchers are heavily focused on novel genetic therapies that target the production of the particle. Here is a summary of the most significant recent and ongoing clinical trials for LPA-lowering therapies. 1. Pelacarsen, antisense oligonucleotide administered as a monthly subcutaneous injection, works in the liver to block the mRNA translation of apolipoprotein A, dramatically reducing its production. LPA Horizon is the first and most advanced cardiovascular outcomes trial in this therapeutic class. The trial completed enrollment of over 8,300 patients with established cardiovascular disease and elevated LPA. Based on the current even accrual trend, the overall study duration is anticipated to be approximately 6 years. Pelacarsen plus inclisiran add advantage trial. This newly recruiting phase 3 trial evaluates the efficacy and safety of pelacarsen in atherosclerotic cardiovascular disease patients who are simultaneously receiving background treatment with inclisiran for LDL-C reduction. 2. Olpasiran, small interfering RNA siRNA therapy administered via injection every 12 weeks. Ocean A dose trial demonstrated that olpasiran safely lowered LPA by more than 95% at its highest dose. Ocean A outcomes, also known as TIMI 75 trial, this phase 3 study is comparing olpasiran to placebo in roughly 7,000 patients with a history of atherosclerotic cardiovascular disease and LPA levels 200 nanomoles per liter or more. The estimated primary completion date is early 2028. Ocean A pre-event, a recently initiated phase 3 trial focused on evaluating olpasiran specifically for the prevention of a first major cardiovascular event in high-risk individuals. 3. Lepodisiran, long-acting siRNA targeting apolipoprotein A. Results from the Alpaca trial recently showed that a single 400 mg dose of lepodisiran reduced LPA levels by up to 93.9 percentage points, with suppression lasting long enough to suggest it could potentially be dosed just once or twice a year. Acclaim LPA trial currently enrolling. This phase 3 cardiovascular outcomes trial aims to be the largest trial among these competitors, randomizing an estimated 16,700 patients across both primary and secondary prevention cohorts with an estimated completion in 2029. Moelaplin, oral small molecule, a daily pill. Unlike the injectable genetic therapies that target the liver, Moelaplin works by directly disrupting the bond between apolipoprotein A and apolipoprotein B, effectively blocking the assembly of the LPA particle. Following the phase 2 Kraken trial, which showed dose-dependent LPA reductions of 47 to 86%, currently enrollment is going on for a phase 3 cardiovascular outcomes trial. 5. Zelaziran. Phase 2 data has successfully demonstrated significant cumulative LPA reductions with successive doses, confirming the durability of the siRNA approach in a clinical setting. It is a small interfering RNA targeting apolipoprotein A.